A 50-year-old man undergoes routine screening colonoscopy. A 5 mm lesion is noted in the sigmoid colon. Colonoscopy excision biopsy done and sent for histopathological examination. Histologically, they are composed of mature goblet and absorptive cells with a serrated surface architecture as shown in the image. Which of the following is the most likely diagnosis? Option A. Hyperplastic polyp. Option B. Inflammatory polyp. Option C. Tubulovillous adenoma. Option D. Tubular adenoma. Let's dive into basics first. Polyps are common in the colon and rectum. Polyps begin as small elevations of the mucosa. These are referred to as sessile. As sessile polyps enlarge, proliferation of cells adjacent to the mass and the effects of traction on the luminal protrusion may combine to create a stalk. Polyps with stalks are termed pedunculated. Intestinal polyps can be classified as non-neoplastic or neoplastic. The most common neoplastic polyp is the adenoma, which has the potential to progress to cancer. Non-neoplastic polyps can be classified as inflammatory, hematomatous, or hyperplastic. Hyperplastic polyps. Colonic hyperplastic polyps are benign epithelial proliferations that are typically discovered in the 6th and 7th decades of life. Pathogenesis of hyperplastic polyps is incompletely understood, but they are thought to result from decreased epithelial cell turnover. Their chief significance is that they must be distinguished from sessile serrated adenomas, which are histologically similar but have malignant potential. Hyperplastic polyps are most commonly found in the left colon and are typically less than 5 mm in diameter. They are smooth, nodular protrusions of the mucosa, often on the crests of mucosal folds. Histologically, hyperplastic polyps are composed of mature goblet and absorptive cells with a serrated surface architecture that is the morphologic hallmark of these lesions. Serration is typically restricted to the upper third of the crypt. Inflammatory polyp. Polyps that form as part of the solitary rectal ulcer syndrome are an example of a purely inflammatory lesion. An inflammatory polyp may ultimately form as a result of chronic cycles of injury and healing. Entrapment of this polyp in the fecal stream leads to mucosal prolapse. The distinctive histologic features include mixed inflammatory infiltrates, erosion, and epithelial hyperplasia together with prolapse-induced lamina propria fibromuscular hyperplasia. The most common neoplastic polyps are colonic adenomas, which are precursors to the majority of colorectal adenocarcinoma. Adenomas are epithelial neoplasms that range from small, often pedunculated, polyps to large sessile lesions. Adenomas develop in approximately 30% of adults living in the Western world by age 60. Surveillance is recommended beginning at age 45 to 50. Histologically, the hallmarks of epithelial dysplasia are nuclear hyperchromasia, elongation, and stratification. These changes are most easily appreciated at the surface of the adenoma and are often accompanied by prominent nucleoli, eosinophilic cytoplasm, and a reduction in the number of goblet cells. Adenomas can be classified as tubular, tubulovillous, or villous based on their architecture. Tubular adenomas tend to be small, pedunculated polyps composed of rounded, or tubular, glands. In contrast, villous adenomas, which are often larger and sessile, are covered by slender villi. Villous adenomas harbor cancers more frequently than tubular adenomas. As the name implies, tubulovillous adenomas have a mixed architecture of both tubular and villous variant. Please do remember, colorectal adenomas are benign lesions. A small proportion harbor invasive cancer at the time of detection. Size is the most important characteristic that correlates with risk of malignancy. Sessile serrated adenomas are type of adenomas. They overlap histologically with hyperplastic polyps but are more commonly found in the right colon. Histologically, these lesions can be differentiated from hyperplastic polyps by the presence of serrated architecture throughout the full length of the glands including the crypt base, crypt dilation, and lateral crypt growth. As we can see, 5 mm incidental lesion in the left side of colon, and on histopathology it shows of mature goblet and absorptive cells with a serrated surface limited to upper 1/3, pointing to diagnosis of hyperplastic polyp. Thank you for patient listening. For more MCQ discussions, mnemonics, and lectures on important topics, please subscribe.